Hello, and welcome to our presentation on psychiatric emergencies, agitation, which will also include chemical sedation and restraint. So pressing forward, we have our acknowledgement of ancestral and territorial lands. Health services across Manitoba are provided in facilities on the original lands of First Nations and Inuit peoples and on the homeland of the Métis Nation. Manitoba's health authorities respect that First Nations treaties were made on these territories, acknowledge harms and mistakes, and we dedicate ourselves to collaborate in partnership with First Nations, Inuit, and Métis people in the spirit of reconciliation. As always, this is a reminder that it is our professional, ethical, and moral responsibility, as well as legal responsibility, to speak up when we see any mismatch or any iniquity in the healthcare system. This is where we make reports. This is where we file incidents. This is where we document on our PCRs. Make some noise when you see a problem. If you see something, you have to say something. So this presentation is intended as general knowledge that can be carried over into any future patient care map update. We could teach care maps all day long, but we also know that the care maps can be changed next week, even tomorrow. So this presentation is meant to provide a general knowledge base that will allow you to adapt to any potential future care map updates as they may roll out. So as we go through this presentation, we're going to touch on the objectives as we see here. So typical psychiatric behavioral emergencies. We're going to talk about the threat to self and others, pharmacology of some of the agents that we have available to us in a very broad stroke. We're also going to talk about then chemical and physical restraint, where and when those might be appropriate, and how to consider those in a somewhat formatted algorithm, and then some special considerations as we go on. So we're going to get into our common psychiatric and behavioral emergencies. Number one on the list, suicidal attempt or ideation. Depending on the degree of distress our patient is in, they may very well be an imminent threat to themselves, and in some isolated circumstances, potentially others as well. Acute psychoses and mental disorders, these can run the range, the entire spectrum from harmless to an imminent threat. Agitation and aggression, keeping in mind that agitation and aggression is more the behavior of concern. It's likely a symptom of something else going on. It's generally not the sole cause of our activation. Okay. Intoxication and substance abuse is a medical emergency, but when we start to put psychiatric components to it, it becomes a psychiatric or behavioral emergency. Medical conditions, we can't forget these because some of the manifestations of our medical conditions, or the underlying cause, if you will, may cause almost like a pseudo-psychiatric presentation. But it's actually driven by a medical issue. So we can't forget that there are other conditions that may mimic psychiatric emergencies. We have to rule out the medical causes as well. Traumas, right, whether we're talking physical trauma or mental emotional trauma, these things can cause a range of responses in patients. So one presentation that wasn't really on that list is anxiety, right? And anxiety, again, just like anything else, can run a spectrum, right? We can have patients who are mildly anxious, mildly distressed, just kind of heightened a little bit emotionally, all the way to somebody who is shut down and essentially unable to function. So anxiety can be in conjunction with another issue with these patients, or it can be standalone. The anxiety kind of sits to itself because although yes, it is a psychiatric emergency, it generally does not present as a danger to the self or others, but it can be very, very distressing for the patient, and sometimes we are required to be able to facilitate that patient or transport that patient to a location where they can start to re-regulate such that they can become functional again. Right. So with that spectrum, We have to kind of assess our patients, and it may be as simple as providing a degree of psychological first aid and just talking the patient down essentially to where they're functional, or we may require some pharmacologic aid to be able to transport or to even continue transport with this patient, depending on where this anxiety state began to escalate. It's all on a spectrum and it's patient by patient. So when we start looking at psychiatric and behavioral emergencies, we are activated generally because there's a behavior of concern. And these behaviors of concern generally stem from one of four causes. The first two are very obvious. The second two are less so and require a little more thought. So the first one is that direct threat of harm to themselves. Right? Whether we've got the overt presentation or maybe a little more subtle, but the patient presents a threat to themselves. The next is the threat of violence to others, right? Or a direct threat to others. It's not necessarily violence, but there is an imminent threat or a direct threat to others. We do have the physical. We also have the more subtle side where people around are affected by the condition as it may be. We may have to watch a little more. The next two are a little more subtle. The first one is direct in that the patient is a threat to themselves and that they cannot affect, due to the nature of their condition or the behavior of concern, they are unable to effectively manage their activities of daily living, right? Food, shelter, clothing, right? They're unable to effectively manage the necessities of life and the patient presents a threat to themselves. The fourth piece here is much the same, but that there is somebody else in the picture, whether we're looking at children, vulnerable elders, vulnerable adults, right? People in special care who, due to the nature of the patient, have a threat to their basic necessities of life, right? And without or without intervention, we believe that one of the above will reasonably occur. Right, so we have that imminent threat to self, imminent threat to others, or problems with the necessities of daily living. Right, but that's involving others. So one of those four general conditions or presentations with the behavior of concern is what generally activates us. How many times can I say generally in one sentence? What it boils down to is if we see something, we can't pretend it's invisible. We have to get involved. We have to activate other resources. This is one of the few cases in which we are able to, for lack of a better term, breach FIA. Because there is an imminent threat or a reasonable threat, we are allowed to breach confidentiality here and activate other resources. If ever you are questioning if you're in a space or in a position to do this and you're not quite sure, OLMS is a very reasonable resource to have a discussion with. So speaking to the pharmacology of the medications that we can provide to assist us in psychiatric and behavioral emergencies, we'll start with our antipsychotics. So they come in two classifications for us. We have our first generation or typical antipsychotics, which are broken down into two further subgroups, our low potency and high potency. The whole difference between them is that we have a lower risk of side effects or a higher risk of side effects. You can see the list on the screen in front of you. I do apologize that it's text heavy. If you need to stop for a second and just kind of look at things, pause the recording. Note that haloperidol, right, is a first generation antipsychotic or a typical antipsychotic, and it's a high potency one, has a higher risk of side effects. You can look up your first generation antipsychotics through any drug reference that we have available to us, whether you're looking at like drugs.ca or UpToDate or Micromedics, anything that's available to us, and you can get a good overview. All the first generation antipsychotics work through the same mechanisms of action. They just have different or varying affinities for the receptor sites. So you can have a good look at that on your own to have a better understanding of how they work. The second generation antipsychotics or your atypical antipsychotics have a lower risk of side effects overall, but this varies by drug because each drug has a different formulation to it. So depending on what is available, or what we're carrying, you need to understand the specific ins and outs of that drug and look them up individually. Okay. Olanzapine sits in our atypical or second generation antipsychotics, right? So we carry both a high potency first generation and a second generation or an atypical antipsychotic in our um, drugs or in our treatments available to us right now. Okay, so those are open. Have a good look at those to have a better understanding, and if things change, you know where to go to kind of update your education and your personal understanding of the medications that we carry. So that's kind of our antipsychotics in a list, right? But note that this list is incomplete. So we're going to speak a little bit now to the pharmacology, how they actually work. So in general, our first generation antipsychotics are a dopamine 2 antagonist, right? They block or inhibit activity of the postsynaptic D2 receptors. You can see that on the screen right there. When we look at D2 antagonism, whether partial or complete, what we get is a reduction in what's called the positive symptoms of psychoses. Positive symptoms are something that adds to the patient's presentation. So illusions, delusions, hallucinations, right? Something that adds to the patient's presentation. When we get this inhibition, we reduce those symptoms. Right. So when we look at things, we reduce the effects of the mesolimbic dopamine, which has that reduction in the positive symptoms. The problem is our D2 receptors or the medications that we provide to inhibit the dopamine 2 receptors, right, to antagonize those sites, are very non-specific throughout the brain. We can't target the specific ones that we want for just the psychiatric symptoms. And we can end up with a lot of issues in the motor areas of the brain. And that's what can give us a lot of our side effects and our discoordinated effects that we can have on our patients. Okay, so all of our first generation antipsychotics generally work through dopamine 2 antagonism. Okay, so essentially you could look at this and say, this is how haloperidol works. Okay, because first generation antipsychotics generally have this mechanism of action. Now, second generation antipsychotics completely depends on the antipsychotic itself. They have varying effects on dopamine 1, and they can have effects on your dopamine 1 receptors all the way through dopamine 5. Okay. So when we get dopamine 1 antagonism, we block, inhibit the activity of our postsynaptic D1, which reduces further activity in the brain and the cortex there, which can theoretically worsen cognitive function. Has not been shown in clinical trials to really have cognitive disabilities in patients, but it is a theoretical potential side effect of these patients. Can lead to a degree of sedation. We have dopamine 2, same as our first generation antipsychotics, but then we get into things like dopamine 3. When we look at antagonism or partial antagonism here, this is where we actually get improvement on our negative symptoms. When we talk about negative symptoms of psychoses, what we're looking at are things that would take away from the patient's presentation. So the patient has that flat effect, right? They don't get happy, they don't get sad, they don't get angry, they don't get depressed, right? The patient is just flat, right? Meh. Nothing in life works for them or excites them or activates them in some way, shape, or form. This helps the patient re-regulate emotional stability, right, and have the ability to essentially feel again. So when we get into dopamine 3 antagonism or partial agonism, whichever way we're looking at things, we have some potential improvements in the patient's mood. Okay. The other thing that starts to separate second generation antipsychotics from our first generation antipsychotics is their effects in dopamine, well, obviously dopamine, but serotonin, right? And serotonin has downregulation or upregulation, depending on the section of the brain that's being targeted. Um, but this has downregulation or upregulation effects on increasing or decreasing dopamine release in other sectors of the brain. This helps us moderate those side effects. So these are the two primary differences between our first generation and our second generation, right? Our second generation drugs are more effective across the spread of dopamine receptors as well as targeting serotonin, which then has downstream effects, both positive and negative, on our dopamine production or inhibition. So when we look at adverse reactions that can be brought on by any antipsychotic, right, any first or second generation, it's just the probability of the risk goes from higher to lower depending on the drug that you are picking. We have at the far end of the scale, right, in the mild side of the scale, we can have what's called acute dystonia, or more commonly known as like lead pipe rigidity. The patient has problems controlling their muscles and they become, stiff as a lead pipe, right? Very difficult to move. Then we get into our acute dystonias, right? Or drug-induced akathisias or pseudo-Parkinsonianism, right? The patient can't sit still, almost like ants in the pants, but they cannot sit still. They cannot control these tremors, okay? And worst case scenario, it goes unrecognized and untreated, and we get what's called tardive dyskinesia. And unfortunately, if the patient reaches this stage, this is their presentation now for life, right? They have acute motor coordination issues for the rest of their life. Right. So what we need to watch for with administration of our medications is the start of any kind of sign or symptom, because these are the major adverse events or adverse effects. What we need to look is for any sign or symptom of muscle discoordination, right, or inability to manage motor skills. Typically, this is from longer term exposure. It is not impossible, but it is very, very rare for this to happen from a singular dose administration. But it by no means does it mean that we, don't need to worry about it, because it is still possible to start into these motor function abnormalities. So the next classification of medications that we need to look at are benzos, right? And we've carried these for quite some time, typically as an anti-epileptic, but now we have them in that that anxiolysis kind of role. We can apply them potentially in chemical restraint, which is what we're talking about today in the context of this presentation. So our primary use for benzos, right, are at least in our behavioral and psychiatric emergencies, are in that anxiety presentation and or in that emergent imminent threat presentation. Okay, so benzos themselves do not actually sedate or reduce the activity of the patient. What benzos end up doing is activating or hyperpolarizing an already active GABA channel, right? GABA being one of our primary inhibitory neurotransmitters. What benzodiazepines end up doing is activating that already active GABA channel and hyperpolarizing it and leaving it open. And what that ends up doing is leading to an increased state of sedation, right? Or to slow somebody down, because we're allowing an enhanced effect of our inhibitory neurotransmitters, or our primary neurotransmitter. In essence, that's what a benzo does. That's how all benzos work. It's just to what degree they have that effect, how long they hold on. Okay, so adverse events or reactions that we can have from benzodiazepines, right? A lot of these we already know. Again, we've carried them for quite some time. And we have to consider that sometimes what is considered an adverse event or a reaction is actually the effect that we're looking for, right? We want the patient to maybe have a degree of weakness to reduce their physical agitation. We're not necessarily going for coma, but stupor can almost be a state of sedation that we're going for to prevent the patient from acting out or to manage the behavior of concern, right? So we have these adverse events, but the line kind of blurs between this being an adverse event and or the therapeutic effect of the medication that we are providing. So we have to titrate as much as possible the doses of this medication that we're providing to our patient for our desired effect. Am I going for complete sedation, or am I just going for a little bit of relaxation? Okay. And that will all depend on what we're doing. One that is not considered, or that we do not have standing orders for, but is covered fairly well in the literature, is ketamine. Ketamine is a dissociative anesthetic. This, if you think your patient requires ketamine for imminent or emergent sedation, understand that this is an anesthetic and needs to be treated as such, right? If we give this in a dose that will be shutting somebody down, I'm not going to speak to it here. We're just talking in general, or at least for the dosing portion of things. Because this is a dissociative anesthetic, you need to be prepared to manage it as such and to call OLMS and have that discussion given the case. This is for an extreme threat situation where we need control of a patient within the next 5 to 10 minutes to prevent imminent harm up to and including a life threat. This is where we can take a shot at chemical anesthesia and sedation of a patient, and this is the better choice to save their life. So this is an extreme circumstance, and you need to treat it as such and have that conversation with OLMS. So if you want to have that consideration in your back pocket, go look up ketamine on your own, pull it up on drugs.com, pull it up on UpToDate, read through it, dive into the literature so that you can actually have that one-on-one conversation with OLMS and truly discuss the ins and outs and understand that it is an anesthetic and it needs to be treated as such. We need to be prepared to run the full way, all the way from just a patient who is essentially now sleeping and safe up to somebody who has gone into complete respiratory arrest, right? We've anesthetized the patient. We need to be prepared to secure this airway and maintain life functions. We've made it an ABC case. Okay, we need to be able to treat it as such. So when we look at behaviors of concern and psychiatric emergencies, right, violence is not part of the job. We come first. Our safety comes first, right? We can't help anybody if we're hurt. Okay, so we always want to be safe, and we treat agitation as a symptom, right? What is actually driving agitation? Very, very rarely is agitation purely the entire concern, right? And essentially, this person is just agitated and being a jerk. There is usually something under the surface that is driving, and what we're seeing is the symptom of agitation as a result of the underlying cause. We need to dig a little bit deeper, gain history and information from family, bystanders, police, whoever else is present, and do our best to elucidate or to elicit what's going on with our patient. Okay? Figure out why the agitation is present. So when we get into these presentations, right, our top tool is verbal de-escalation, right? So we'll talk some about this. So first, again, our safety comes first. Have an exit strategy. Never put yourself in a situation where you are cut off from safety, right? Our safety comes first. One-to-one engagement. We have somebody who's in crisis. We want a singular point of contact. And it doesn't really matter whose attend it is, quote unquote, right? If the patient has a better response to one medic on scene versus the other, the medic that they're having a better response to just became primary on the case, right? It's about the patient here. Our safety comes first. If we have a better response from one medic to another for this patient, it increases the safety, right? Change things up, right? When we think of watching our tone low and slow, no, that's not talking low and slow and like antagonistic to the patient, right? We're not baby speaking to them. What we're doing when we think about low and slow, right, is that we're speaking to the patient in a cadence, and the volume of information that we're providing to them, or the discussions that we're having with them, are at a speed that allows them to effectively process things, right? These calls sometimes take what they, the time takes what it takes. You might be on scene for 20 minutes. You might be on scene for an hour and a half. It takes what it takes. And if we can do things without resorting to any kind of physical intervention or chemical intervention, right, we've had a best case scenario. Body language, how you say it. Think about how your physical presence in the room affects a patient. Think about your body posture and your positioning. Are you unintentionally uh, making yourself out to be an increased threat to this patient? Are you challenging them through your physical presence? Right. Just think about how your body language is speaking to the patient. Respecting personal space, right? Give them some time. Allow them to warm up to you, right? Build some trust. These patients, if they're not in any kind of medical distress, right? We're dealing more with a psychiatric behavioral issue. They generally don't have an ABC issue, and we can see, airways patent. They're talking to me. Things are going okay. They have effective perfusion, right? We can see these things, right? And we can take some time before we actually end up getting our first set of vitals or anything else. Again, right, we're having this conversation with the patient before we can effectively evaluate them. We need to de-escalate them, right? Now, that being said, we can also set and reinforce reasonable limits. You are not a punching bag, right? Violence is not a part of the job, okay? And if the patient is agitated to the point that you can't perform that job safely, right, then you have every right to back out. We have the right to a safe work environment, right? We're also not expected to sit there and endure a constant slew of verbal assaults, right? That is, we're not there to be a verbal or physical punching bag, right? And it doesn't do anything for us or for the patient to sit there and, effectively just quote unquote take it, right? And ignore challenging questions. All we're going to do is get into a power struggle, right? It literally just, I'm not going to engage in that with you. Okay? So that's kind of how we can approach things and consider things. Now let's look at the components of psychological first aid. How do we actually speak to a patient to de-escalate them? First thing we want to do is protect that patient from further harms, or others from further harms, right? So there may be somebody on scene or somebodies who are actually escalating and antagonizing the patient, right? Whether intentionally or not, the presence of this person is antagonizing the patient. Maybe we need to remove somebody from scene or create some space so that that patient can actually have a chance to effectively catch their breath and start to come down, right? Talk without pressure, right? We're not setting time limits like you've got 5 minutes to talk to me, or we're going to grab you with the police. Talk without pressure. Allow, have the discussion with the patient, build some rapport, allow that time to take what it takes. Active listening, right? When we talk about active listening, we're not meaning that you are completely understanding the patient, but that you're doing your best to take in what they're saying and that you can effectively relay what they're saying back to them, or at least show that you are trying. Some patients are distressed enough, or their psychosis is deep enough that we can't follow where they actually are. But what we can do is show that we are actively trying to understand them, right? And in doing so, this shows a degree of compassion to the patient. They might not be able to, or they might be a little bit frustrated that we can't understand what they're saying, but quite often they will react positively to us trying to understand them and show that little bit of a human side, essentially. Okay. We can acknowledge their concerns. Doesn't mean that we agree with whatever's going on or agree with their point of view, but we acknowledge that for this patient, this is their concern, and that to them, this is valid. This is how they're perceiving things. Right? Now, discuss coping strategies or mechanisms. We're not necessarily playing a therapist right on scene, right? We're not necessarily providing the patient with de-escalation tools and ways to self-regulate and manage. What we are potentially looking into here is what are the strategies or mechanisms that they have used to de-escalate themselves before, right? What has worked before? Do they follow up with somebody? Do they have a counselor? Do they have a psychiatrist or a psychologist? Is there somebody in the mental health community that is actively looking after this patient? Or there's their family physician, whatever the case might be. What has been provided to help them before? And last, when we look at social supports, has there been something that has changed recently to these coping strategies or mechanisms, right? They were following up with a psychiatrist, but their practice is closed or their practice has moved, right? And they no longer have access, or they've had to move and they no longer have access to the usual supports, and their life is now kind of in a state of distress because they are trying to re-regulate in a new situation or in a new area. Right. So these are all things that we can kind of consider and that we can put together to try and de-escalate our patients and or set things up such that the patient will have a better chance of success after we've engaged them with emergency care, right? Whether we've taken them to an emergency department or another appropriate destination. Right now, we're basically looking at transport to emergency departments, but in future, things may change. If you think there is a better destination for this patient, have a discussion with OLMS and or OCS, because now we're looking at both medical and operational issues. Okay. So in managing psychiatric behavioral emergencies and potential behaviors of concern, we have options open to us when we look at our pharmacologic agents. But how do we choose those, right? How do I choose the difference between one or the other or potentially both? Well, I think of the cause, right? So our antipsychotic agents, right? The answer is kind of in the name there. If I think the primary cause of the behavior of concern is a psychiatric issue, then I'm likely reaching for an antipsychotic as my primary option. If, on the other hand, I'm either dealing with anxiety or the behavior of concern has escalated to the point that I need emergent control of a patient, then I'm likely reaching for a benzodiazepine, injectable or PO, as is tolerated. Keep in mind that just because olanzapine is only listed at this point in our care maps for methamphetamine psychoses, there is absolutely no reason you cannot call OLMS and have a discussion, if you've got that rapport with the patient, to provide an oral antipsychotic to a patient who's maybe having a behavioral emergency with a psychiatric component to it. There's no reason that that discussion can't be had. Okay. Just think of your primary cause. Am I dealing with a psychotic, or not psychotic, but a psychiatric emergency primarily? Then I'm looking generally at an antipsychotic. If I have that imminent threat and I need emergent control on the patient, then I'm likely reaching for like my injectable midazolam, which is also, you can mix it with Halidol or haloperidol. They can go in the same syringe for a singular emergency injection, right? Or am I looking at potential oral agents, right? So unfortunately, we're getting to the point now where, as it says, diplomacy has failed, right? So now we have to engage our patient in either chemical or physical restraint, or potentially both, right? We really need to put some emphasis on the chemical restraint. That is, if we have to get into a restraint situation, that is the ideal way to manage a patient. It has the least likelihood for injury to ourselves and or our patients. Okay. So before we get into providing chemical sedation or administering chemical sedation and or physical restraint, we need to make sure that everything is ready. You've got your meds drawn up, they're labeled, they're prepped, you know where they are. It's not a case of grab the patient and then start trying to figure out what the drugs are, what the dose is, trying to draw things up. This is a very prepared, rehearsed, fast event. Okay, you have all of your equipment necessary for resuscitation if this goes bad on us, right? You don't want to be behind the 8 ball here. I mean, worst case scenario, you've got everything set up and you don't need the BVM. Well, you can either put it back on the shelf, or if you're, maybe it's you're thinking it's contaminated in some way, there's spit or something on it, throw it out and get a new one. A BVM is a BVM. We have lots. Okay, so prepare anything that you need appropriately. We do not carry spit hoods. Just that is on this list here. Okay, what personnel do you need? Right? Do you need RCMP or do you need MFNP? Right? Do we need law enforcement to seize somebody for a mental health emergency? There's a big difference between, the teenager to 50-year-old raging on meth compared to the 50 to 70-year-old who's having an acute delirium because of infection or something like that. So do we need police, law enforcement? Do we need more medical hands? What is appropriate for this situation? Make sure you have the personnel that you need, right? Don't try it if you don't have enough hands, right? Wait until you have effective resources. Now, if we do have to go hands-on with patient, let body mechanics play to your advantage, right? Use mechanical advantage and leverage. If we do this, if we take away joints, right, as we hold somebody down, right, we take away that range of motion and we reduce the risk of injury. We're not arm barring patients, we're not joint locking, we're not twisting people up. We're removing range of motion, right? Holding somebody by the wrist allows a lot of upper torso and arm motion, allows people to retract. Whereas if you hold them by the shoulder and the bicep, down onto a bed, up against a wall, against a car, whatever the case might be, we take away a lot of range of motion. We can hold somebody steady. And this can be for both, right? You could be holding somebody for 10 seconds with RCMP or police, whatever the case might be, to administer that emergency sedative injection into the lateral thigh, right? Make sure that everybody knows the plan, what your predicted injection site is, what the backup injection site is, so that that area is clear and we reduce or minimize our risks of a needle stick, okay? This can also be considered as you potentially have to physically restrain and tie a patient onto a bed, right? Use the joints, right? Use these locations to remove range of motion. It reduces the amount of exertion on us, which reduces our risk of injury. It provides a higher degree of control for our patients or on our patients, which allows a greater degree of safety, again, for us, while reducing the relative risk of injury to the patient. Okay. Physical intervention is the highest risk point here for us becoming injured. Okay, so if we have to restrain, how do we do it? Right? Well, we get our patient down onto our bed. Step one. Now you can tie these from whatever your restraint, you can tie them however is appropriate for the devices you carry. But for the lower extremities, right, we recommend tying them to the opposite sides of the cot so it doesn't allow the patient to kick out. Right, it restrains their legs a little bit better. Now you can start with the legs, you can start with the wrists, whatever's appropriate. Tying the wrists, obviously this goes to the same side of the stretcher, but when you tie these restraints down, loop them and then move the knots, which should be a one release slip knot, or a quick release slip knot, move them away from where the patient can reach. Before I was in EMS, I was in hospital security. So, I mean, this is going back, we're looking at the early 2000s, but I was in hospital security. Okay, you can have the most demented, most confused, altered patient. They're even almost to the point of being nonverbal. If their hands can find the knot on your restraint, they will untie it. They will find a way to get it loose. Right? They will fiddle with it for an hour and a half, and eventually they will get lucky and they will get it out. Right? So loop your restraint and then tie the knot somewhere further away from the patient such that they can't reach it. Okay. Now, job's not done. We still have seat belts on the stretchers. Okay, so we then apply our seat belts, and these can be a restraint in and of themselves. It depends on your intent. Okay, so a patient may not require actual physical restraint. They might not need their arms and legs actually tied down, but they may have dementia or confusion to such a degree that they can't be transported safely, and they keep fiddling with the seat belts and the buckles and trying to undo themselves. It's not the first time that we have put a patient on a stretcher and then towels and taped towels or something around the buckles such that the patient cannot access them and release themselves. In doing so, we have changed the intent of the seat belts on the stretcher from that of a safety device to that of a restraint, and we now have to treat it and document it and monitor as such. We have used them intentionally to remove somebody's range of motion to restrict their freedom. Okay. So here's where I was discussing about tying that knot away from where your patient can reach. So you have it looped at the towards the patient's arm, and then the knot is tied further away. Okay. So through all of kind of our clinical stuff, here's a general flow recommendation. Okay. So if we have an imminent threat of some sort, this is where we're likely considering that emergency chemical restraint and then hoping that the patient calms down after a dose or two to the point that we can safely move and transport them, that they become sedate enough to be managed. We can have active or worsening symptoms of psychoses. So we can consider sedatives or antipsychotics as appropriate, administering again through the least invasive route possible. So even with these active or worsening symptoms, if you can get a degree of rapport with this patient to the point that they will take an oral medication, have the discussion with OLMS to use olanzapine, a second-generation antipsychotic, as an antipsychotic. Right? It's potentially worth that conversation. That can prevent escalation of a situation and make it safer for everybody involved. Now we have isolated psychiatric or behavioral disturbances. Likely your primary go-to there is an antipsychotic, right? And then amphetamine psychoses or anxiety in isolation, right? Then we can look at our appropriate oral agent or agents, right? Whatever's necessary for the patient here. And almost all of these can be considered with or without physical restraint as necessary. The higher on the list you are, the more likely or the more indicated physical restraint may be. But again, keep in mind that physical restraint presents the highest danger for everybody involved, ourselves and the patients, okay, or others who are assisting us. Okay. Now, some special consideration. Methamphetamines, right? The 55-hour energy. Why is olanzapine our agent of choice here? Olanzapine is a atypical or a second-generation antipsychotic, so it has that dopamine, mixed dopamine agonism and antagonism, depending on whether we're looking at dopamine 1 through 5, as well as our serotonin inhibition, right, or agonism, mixed effects again, depending on where we are in the brain. It's a very broad spectrum antipsychotic in that it hits a lot of other receptors as well. It tickles the benzodiazepine receptors, right? So our GABA channels, right, causes some activation there. Hits histamine. It hits as well our some alpha channels and a slew of other receptors throughout the brain. It's very broad spectrum, kind of a shotgun approach. It's not quite sure what's triggering things off, and it kind of suppresses it all. And a lot of the extra effects lead to that degree of sedation and moderation and symptoms. So it has both our sedative properties as well as the antipsychotic properties, which are the primary effect that we're going for with this medication, is that antipsychosis, but it works on both positive and negative effects of psychoses and has a degree of sedation as well. Right? So it works very well for our amphetamine patients to kind of bring things down. Now, autism and spectrum. This is exactly as you read it, a spectrum. This goes right from a mild case where you have somebody who's essentially just a little bit socially awkward, all the way to severe patients who are almost nonverbal and resistant. Take them in context of an emergency. One to even think of would be like a car accident. Mom, dad, primary caregiver, whoever it is, has become injured or is no longer available to the patient, right? This patient may actively resist you, not because they are actually violent and trying to hurt you, but because their primary caregiver and their sensory perception and overload is just off the charts, and they cannot maintain, they cannot process what is happening, and so they resist and they lash out. Okay. These patients are not intentionally being a threat to anybody, but trying to physically restrain them may actually be worse for this patient than trying to sedate them and then provide assessment and care. Okay. So we may have to consider sedation for these patients in almost that they are a threat to themselves. Not that it's actually a psychiatric emergency, but it's a behavioral disturbance that is preventing effective assessment and care of this patient. We're also reducing the overall distress in these patients in severe situations. Right? It's not ideal, but it may be the best way to approach these patients depending on the level of their disorder. Okay, now dementia and delirium. Okay. The special consideration here is that in delirium can be added on to a dementia, right? You can have an acute illness that is causing worsened psychiatric symptoms or perceptions of their environment and reality. Okay, dementia is here for life, right? It's insidious and it progresses throughout the course of the patient's remaining life, right? And it just gets progressively worse. Okay, whereas delirium has a relatively rapid onset and it fluctuates, right? They get bad, they get better, they get bad, they get better. We can reverse delirium, whereas dementia, again, it's here for life. The catch is, in delirium, benzos can actually make things worse. So if we identify a potential delirium state on a patient, antipsychotics is likely the answer. If we're pulling benzodiazepines out, it's because the patient is in a severe delirium and they are presenting an imminent threat and we're going for total sedation, right? We're not using benzos in a delirium to take the edge off of somebody because we stand a much greater likelihood of actually making it worse and exacerbating their presentation. Okay. Food for thought there. You can have a good look up and a read on that to get a better understanding. Okay. Benzos can get us into trouble here. Right. Sorry. Now, last but not least, stimulant toxicity. Okay, this is starting to think of those medical causes, right? So you have somebody who's taken a load of ecstasy or acid, PCP, anything like that, right? Cocaine ODs even, right? Or stimulant overdoses, as it says, stimulant toxicity, right? Know the signs, right? We can see these in our patients: anxiety, paranoia, confusion, panic, hallucinations, agitation. They're in a degree of psychological distress. Also, we have the potential physical symptoms, right? These are things that we can quantify through our assessment. A lot of this we'll get through history, okay? But if we have a stimulant issue, right, we've got a lot of adrenergic stimulation or sympathetic stimulation, right? We can add a benzo to start to moderate those symptoms, right? So just keep in mind that in these stimulant presentations, right, what we're seeing are the symptoms. If we look at the root cause, right, we might find a better option. Okay, so a little more food for thought there. Outside of that, this is the end of this presentation. Okay, so if you have any questions, comments, thoughts, concerns, please reach out to any member of the provincial education team and we will be happy to provide further resources or to discuss any points that you have some confusion on. And with that, I thank you for your time.